Shall we start, sir?
Please.
Good evening to everybody, and welcome to yet another webinar of the Clinical Practice Oriented Webinar Series CLIP of the ISC National. This is the 11th webinar of the CLIP series, and for this session, we have our screen coordinators, Dr. Swati Ojha, who is Assistant Professor, Government Medical College, Pali, Rajasthan, and Dr. Niharika Das, Senior Resident, AIIMS, New Delhi. So I hand over the proceedings to the screen coordinator, Dr. Swati Ojha. Thank you.
Thank you, Madhuri ma'am. A very good evening to all present. Myself, Dr. Swati. A warm welcome to all our esteemed senior members, coordinators, and distinguished panelists and delegates who have gathered here today for the Clinical Practice Oriented Webinar Series. I express my sincere gratitude to Dr. Sukhwinder Bajwa sir, Honorary Secretary, ISA National, for his constant support and guidance throughout the CLIP webinar series. Now I request sir to address the gathering. Over to you, Bajwa sir. Thank you, sir.
Thank you, Dr. Swati. Actually, the topic is quite common among everyone. I think right from your first year of postgraduate career to later on your different part of careers, whether you're in practice or in an institution or wherever you do the practice of anesthesia, critical care, pain, or even emergency medicine. I think this situation must have been faced by someone more than once. And how you really deal with these type of situations, it's altogether a very different scenario, different type of people, different reactions, emotions, and also there are different cultural barriers, religion, region barriers, linguistic barriers. So many things are there. So there is not one solution which we can always arrive at and say that this is the protocol, do like that. But today, what we will be doing, discussing all these aspects under the cover of one protocol and a protocolized manner. I think where our panelist and moderator, Dr. Purushottam Gautam, we will be dealing with some structured way so that in future, if such situation arises, so how can we go about communicating to the patient relatives or to anyone else when we are going to break the bad news? Because sometimes, it's an individual, subjective, you may be very superior, but it's not the uniform, what we call the existence of these type of behavior in everyone. But if you follow certain rules and protocols, I think we definitely will be able to make a mark, definitely able to save everything, save the scenarios. And with the rise in the violence against doctors, these type of topics are very important for a whole some discussion. I know that period is very short, but I think our elite panelists have done a wonderful job in preparing this, and they are prepared to answer anything from the audience. In the first one hour, I think we will be interacting with their discussions in a structured manner, and then we will switch over to the audience queries and question and their experiences. Back to you, Swati.
Thank you so much, sir. Thank you for the enlightening words. Now, I would like to introduce my co-coordinator for today, Dr. Niharika Das. She's from Delhi. Over to you, Dr. Niharika.
Yeah, a very good evening to everyone present here. I welcome you all to the CLIP series. Now, it's of immense pleasure and a great opportunity for learning and also for a great honor that I'm here. I'm able to introduce all of you to the CLIP series and also to our audiences, our eminent moderator and our faculties that are present here. I'd like to introduce the moderator. Our first moderator is Dr. and Professor Purushottam Lal Gautam sir. He is the head of critical care medicine, then Medical College and Hospital. His main areas of interest are crisis resource management, patient safety, trauma and liver transplant care. He has received multiple awards, MNAMS, then Fellow of Indian Critical Care Medicine, ISCCM, President Citation. He has also received fellowship in the liver transplant anesthesia. He's a teacher and examiner for DM Critical Care and also a part of National Board of Examinations. He has authored multiple books and published many journals in national and international journal club. Our next speaker Dr. Pratibha Kane, who is the MD anesthesiologist, and she's from Jehangir Hospital, Pune. Her areas of interest are neuroanesthesia, pediatric anesthesia, and training and communication skills. She is the past president of ISA Pune City, and she's also the gold medalist for ND anesthesiology.
Dr. Niharika, can you just widen the screen?
Ma'am?
Widen the screen.
It's okay, Niharika. If not possible, then go ahead.
Okay.
Ma'am, it's in full screen mode.
Anyway, Niharika, please go ahead. Don't worry.
Okay.
Go ahead.
Yeah. Our next speaker is Dr. Anjum Khan Jod. She's the Director of Anesthesiology on Palliative Care in Bhagwan Mahavir Cancer Hospital Research Center in Jaipur. She has done her MD from BJMC Pune in Palliative Care from Australia, UK, and San Diego. Her areas of interest are anesthesia, palliative medicine in cancer, acute pain, and end-of-life care. I welcome our moderator and our panelist to the session. Now I'd like to hand over the mic to Dr. Swati to welcome our next set of panelists.
Thank you, Dr. Niharika. Now I take the honor to welcome our next panelist, Dr. Ilango Ganeshan. Sir is Professor and Medical Superintendent, ESI Medical College and Hospital, Chennai. He was past President, ISA Chennai. His areas of interest are interventional pain and regional anesthesia. Sir has received Doctor's Day Award from IMA Tambaram in 2023. We welcome you, sir.
Thank you. Thank you. Thank you all. Good evening.
Our next panelists are Dr. Anupam Das, sir. Sir is currently working at Dr. Bhuvneshwar Goraha Cancer Institute, Guwahati. His areas of interest are difficult airway and onco anesthesia. He was ex-joint secretary ISA Guwahati, which also received Best City Branch Award under his tenure. A very warm welcome to you, sir. Now, last but not least, Dr. Shamik Paul, sir. He has done his MD from AFMC Pune and DM in neuroanesthesia from PGI Chandigarh. He has done his fellowship in pain and palliative care. He is professor and commanding officer in Army Hospital. His areas of interest are trauma, including neurotrauma, innovation, geriatrics, pain medicine, and palliative care. Sir has received multiple military awards like Army Commander's Commendation 3 times in last 8 years. Chief of Defence Staff Commendation Best Innovator Award in KHOTEC 2023. A very warm welcome to you, sir.
Wow.
Now, I would like to share few rules for today's session. During the course of talk, audience will be muted by the host. Any queries will be discussed at the end of the talk. Audience are requested to switch off the videos. Audience are requested to put up their questions in the chat box. Thank you. Now, I would like to hand over the stage to Dr. Purushottam, sir. Thank you.
Good evening, every senior peoples and Dr. Bajwa and other members and dear friends and the delegates and the candidates who are joining. I know there are many senior people. Most of these communication skills, the senior people like to join more than the junior people. But it's very important topic, very close to my heart also. So let me share my screen. Just a minute. Just bear with me because I want to make it slideshow. Okay. So today's we have this very good topic, that is breaking bad news, the role of communication. I would call it more of effective communication. So we have very learned panelist along with Dr. Bajwa, Dr. other members. So what we are going to see in learn today is the learning tool. First thing is we are using the case-based scenario in this total this thing, and these are based on the real case scenario. What I'm have brought to discuss because everyone has a different experience, values. So breaking bad news and crisis resource management two are their different aspects, but the communication is both in the both very important. So we have different ways of communication: verbal, non-verbal, and written. And it goes one-sided, two-sided, and sometimes it goes in a helical way. That's a transactive. You are going stepping forward and backwards during a discussion. So once we are breaking the bad news, it's a little different. But when we are going with the crisis resource management, it's a little different. So if you go with, I would say the literature, you find the communication skills, they are really sometimes the motivator people are there. They change the word, but there are a couple of examples where rather more than a good communication, a bad communication makes the things worse. That's what important is in breaking bad news also. Like people have the poor listening skills, inattention to concern, lack of appreciation, and just they are rude. But that is very important in the breaking the bad news. There is Egyptian president was just put down just for that reason. So taking with that, I will start with Dr. Pratibha, that effective communication is it's a God gifted item or the quality, or it's a can be learned or taught, and if is learned or taught, what is the best way to do it, and what are similarity and dissimilarity while communicating in different scenarios? Because each communication has a different person, different personality trait. I mean, how you take it in that way?
All right,
But,
so thank you for this question. And yes, good communicators are really gifted, but communication definitely can be learned. And they say if you don't have the art, then you must learn the science. So programs like this are really required, and also workshops which teach and actually, kind of give tools for effective communication. So that being said, I will like to say that communication, especially if you want to make it effective, is has three main skills. So one is the content skills. Those are the words that you say, the choice of words. The second is the process or the delivery. So it is the way you say it. And the third, actually, which we normally ignore, are the perception skills. And these perception skills is what the patient might feel after your interaction. So Mehrabian is the person who has actually given the value of these different communications in delivering message. So he had this rule which is called the 7-38-55 rule. So what you are, the message that you are giving is communicated only 7% by the words you speak, 38% by the tone of your voice. So you can imagine how the tone of voice is so important, and 55% by your body language. So we need to learn all these to be able to effectively communicate with the receiver. The other thing I would just like to just add is about perception skills. And perception is how does your patient receive your information. So perception is actually vibes, you can say. And so does he feel, comforted? Does he feel the rapport? Does he feel hope? These are all the feelings that are important. So sometimes they say that even if you have done the best medical treatment, if your perception by the patient has been of insult, then they will not appreciate the medical outcome. So all these all these tools are important to try to make it very effective and patient must feel satisfied. uh, Talking to patients and is different from talking to your colleagues or talking to your co-workers, and that is because of the content. So the content we definitely make a difference. For the patient, the consent, at the time of consent, especially when you are sharing or when you are talking about risk, then it is important to use all these communications so that the patient feels confident about you in spite of the fact that you're talking about risks. With the physician, the content is more scientific. It is more about, if you're talking to a physician, more about comorbidities, more, these are professional communications, and they are definitely slightly different from the way one would communicate to the patient or the family.
Thank you, Dr. Deva. I don't think we have.
Learn these different scenarios, so I'm not going to talk. It
Yes,
is
I will go with that. So I think very rightly said, the content, how do you communicate your language and your body language, they are very important. And when you are throwing the information to the patient or patient's family, then how it comes back, that's also very important. You have to change your modulation and other things, looking at reactions also. So what we call is more of when we have already discussed very nicely that when we are talking between ourselves, it's more of information is content is different, that we want to work as a team. But when we are like a crisis resource management, where the communication is more of collaborative. But once we are talking to the patients, and that's very important, it's a more of trust, empathy. We have to convey in a different way. Our emotional component is different, so which can lead to misunderstanding. So now coming with the case, it's a real case scenario. Based on that, we received one female who was 70 kg short stitch, referred from a private hospital to Katashike. She had proven diagnosis of respiratory distress. She has even bronchoscopy done because of respiratory distress. And after that, she went in a different way. And just a short history, 5 6 days. The differential diagnosis was in confusion, whether it's LGBS or neuroptic myelitis and optica or OPC poisoning or something like that. So diagnosis is doubtful and most investing were normal. So cross consultation was sought. So this question is to Shamik, that once we are taking the because I'm before the medical breaking the news, anything, how we communicate ourselves, how will you arrange, how will you take help, what are the key points when we are communicating with our team, and more about you are in from army, because the communication skills are very important. You have wireless copy like that using the words. So can you comment on this?
Yes, sir. Thank you for the question. So the patient who has come to you right now is extremely anxious. There's a lot of uncertainty. Probably she has been traumatized with so many investigations, invasive and non-invasive, and now she has come to us. We need to have a sense of urgency as well as try to solve the confusion diagnosis by various other modalities. And as you rightly said, sir, the patient does not have, she is very uncertain, and we require expert consultation. Now, once the patient has come to us, we need to ask for help. Asking for help from experts is very, very important. And we need to not only ask for help, but we need to call them up because probably this patient has come in right now and we don't have previous information about the patient coming. So we need to call the patient up, the specialist up, and tell the specialist about the patient. Now, there's a huge gap sometimes in what you mean to say, what you actually say, what the person hears, and what he understands. So, like in the ATLS, we also have a way of communicating the when the patient comes to a primary healthcare setup and being referred to a doctor in the tertiary healthcare setup. We need to communicate after the ATLS primary survey and just before the secondary survey starts. That also time we do use a way of protocol of communicating the condition of the patient by the acronym ISBAR. So it is very well prevalent in ATLS, and we are doing it. ISBAR is a good way of communication to the doctor whom you are referring to or talking to, which deals with introduction, as in you introduce yourself probably in a closed setup where you are working, people will be knowing you, or if you are referral outside, so you need to introduce yourself. A situation, exactly why are you calling? What is the urgency? So the urgency has to be said and it has to be expressed. What is the background? What has happened? Was she a case of poisoning and she was not recovering? The initial assessment of the patient which you have done after coming, and what treatment you have given and what are the recommendations from his side till he comes there. So this is a very important part of communicating the urgency and patient's condition to the referring physician. Now, what is different in the army? Well, the important thing is that army do have combatants and non-combatants, like and dependents. So when it comes to combatants, we do have a prior intimation in a tertiary care center as to who is coming and why is he coming. The casualty evacuation is by road or by air. So we do have a prior intimation. So our emergency team of who is going to receive the patient is already ready. We have got a code blue that is activated. The anesthesiologist or anesthesia resident along with the team is already there in the airstrip or in the on the emergency bay, and we have already followed the ISBAR way of communicating, and it is the way we do communicate, and it is quite protocolized. When it comes to dependents and civilian casualties, we also follow the same thing, but we need to refine it a bit more. And whatever I just said about what we patient, exactly the same will be following when it comes to others. Thank you, sir.
Thank you, Doctor. Actually, it's become very important also once we are going with the patient too sick, if we have a teamwork, communication and other things being conveyed to the patient attendants also and the patient, that gives them more of confidence to them also that they are working in a team, and they have a more of trust also. So the same case when we were getting this the doubtful investigations, we have one of the neurologists. He was very good. He made the diagnosis that most likely it's a neuroptic mellitus optica, and they got the MRI done, and patient required the ventilatory support. So family, this patient was from a business family and quite educated one, but these people are very demanding also. And one of the close relative was, one was advocate, second was doctor also, although not MD, but more of people who are RMP type. So that's the next question going to. So how will you, I mean, have to have the family meeting, then how you prepare for the meeting? Dr. Ganesan, you can comment on that. So side by side, we will go, then others comments also. Then because there are a lot of ways, structured meetings we arrange, but these sort of meetings are easy. But sometimes if communication goes a little down, it creates a pitch for the poor further violence and other things which Dr. Bajwa was telling.
Yeah, good evening, sir. Good evening, all. Actually, that you said that family is very well educated. They're very anxious, and already a learned person like advocate, doctor is in the family. So first of all, you should have a prepare for the meeting, and you should prepare it in advance when to the right timing, and also most important thing is you should have a background information about the disease. The disease is almost diagnosed, and what are the possible differential diagnosis, what are the treatment protocols available. All these things should be prepared in advance. Since the patient's relatives are advocate, so you have to choose the right words, and your communication should be like crisp and clear. uh, most of the things they might have also googled with the chat gpt and things, they might have got the information. So you should assess the patient's attendance and the patient's family also, the what information they know, and if they might confront you with many questions, whether this is the right diagnosis you have taken. Like the previous speaker told, the cross consultations have been taken. All those information might be asked by the relatives. So first thing is you have to prepare and you have to be confident and you have to be boldly face the situation. And the goals are like you have to make them comfortable. You have to show compassion, or you have to show, I mean, compassion and empathy should be there, so that they get confident with your information.
But what
So
other question is many people, I mean, they are always interested in the outcome. That is the most times the first thing they always try to come with this outcome. What should be the outcome? What is going to the outcome? That's very important for them. I mean, they always put a lot of weightage to that in percentage. That this liver is down, this kidney is down, failure, because they don't know the words also. So how do you take these things also? I mean,
Exactly. Actually, when you communicate to them that it should be in a comprehensive language to the lay persons, since the doctor is also already there, you might interpret something, but the perception of the relatives should be also taken into consideration. So, and the prognosis as well as the treatment protocols should be clear. First of all, you should make yourself clear what is your treatment strategy and what could be the prognosis. Here, you have to be very clear in your treatment options given to the patient, and you should not hide the information. Prognosis should be clearly told. This being the autoimmune disorder, the patient might ask you many questions. What will be the prognosis? What will be the outcome of the patient? That you'll have to be guarded in just delivering the information. So if you give false hopes or false promise, that might land you in trouble in the later on stages. So at the same time, you should not make them feel frustrated, dejected. They might feel that you are not like showing as if you are not confident enough to treat the patient. So you
yes,
should.
that is very important. Actually, showing the confidence that gives a lot of confidence and them also trust also.
Yes.
And the very important is that we should know what their wishes are there, what is their background. It's, I think it's more of a psychological sport also, because they are troubled at this moment. They are not able to comprehend their. That's very important. I mean, they need a sport as well as giving the true information. If you don't have the information, we should not have a false commitment. We should keep some leverage that rather than, but they always look for the these things. So, and another thing is, if they are asking for like a treatment options or something else is there, somewhere else we can go. How do you address that also? I mean,
Yeah, definitely. But we should not be thinking that the financial option. We have to give them the cost-wise, the treatment protocols, the available choices of the treatment. So, what are the best possible treatment can be given at this center, and also you should give an opportunity for them to, if any other treatment, better treatment is available next any other higher center, that also need to be shared with them. So, you give the autonomy to the patient to choose their choice of treatment as well the place of treatment. So here we will have to play an ethically we have to just support them, because they are emotionally down and socially also sometimes they may be sound or may not be sound. So based on their input, and we'll have to decide whether to take the treatment here only or we have to refer them to any other center. So
so
whichever is
thank
the.
you. Yes, thank you, Doctor. That's very important. So first meeting is so important. The later on meetings will be a little less taking time gradually, but the first meeting is very important, where you have a lot of prognostication, background information, and clarity, these things. And we always empathetic, that is compassionate, because it's our job to be patient and patient family who is sick. That's there. Now, this patient was put on ventilator. After 2 3 days, then this patient, while in the morning, early morning, one consultant was sleeping in the room, and the SR was had gone to coffee room, and the JR was only the sisters were changing the position, and suddenly the patient's had accidental extubation, being a little weak. So it took some time to intubate the patient and put the, but it was really risky. Then the SR was not getting conducted because he was away. So patient was had a CPR but got revived. Now, because this patient's family was not at their place, so how will you now? We have gone a little bit that mixer of two things. One is some fault from our side also, but the patient has got the insult also brain wise. So we want to now have the meeting with the patient. So how will you approach the family for meeting? Who is at home now in the early morning, 4 o'clock, 5 o'clock in the morning? Or Dr. Anupam, can you just uh, take this call? How do in practice? And I know it's not easy. Every one of us face these things. Even I have faced many times. To go there, because sometimes the residents make something that, and sometimes the gray code is also activated in such situations. So how you take these calls?
Yes, sir. Thank you for the question, sir. At the very onset, I would like to express my view that even though, sir, you have given us the background, family background, which is very much important, but I think that since she is just a 15-year-old child, the emotions of whether the parents are educated or not educated will be same. So when we think that we think of the family as they are educated, influential, have doctor or advocate, then I feel we should be say equally we should be treating each patient equally, whether from whatever background they are from, because the poor patients who are not very much literate, they are just afraid to talk to the doctor, to ask the doctor freely. So that's the only difference. Otherwise, emotions are same. Now, coming to this situation, that the emergency which has happened right in the morning time. Now, before going to this catastrophic situation early in the morning time, what I would like to emphasize, the previous speakers have already told about this, that actually a good, effective, and adequate, detailed briefing of the patient's medical condition right at the onset when we are exposed to the patient attendance is very much important. In fact, that first meeting, that first conversation sets the backbone, is the backbone for all further communications. So this child, while when she came with breathlessness, history of breathlessness, so if a senior doctor attends to her attendance and then tell the prognosis, though at the initial time the diagnosis was not very much sure, but still it was breathlessness. So that will help a long way in building trust with the attendants. So, and then when the patient was shifted to the ICU and was put on ventilator, so every patient who are put on ventilator are a critical patient. So what we should do, we should all do, whenever we put patient on ventilator, we take consent from the attendants, and then we explain all the risks involved in ventilating the patients. That may include the known risks, long-term risks like ventilator-associated pneumonia, or acute risk conditions like the extubation which has happened. It may be accidental kinking of the tube, maybe disconnection of the circuit. We all should, in a way, let the attendants know that these are the risks which are involved in putting patients on ventilator. In a way, this sort of communication right at the onset, it works like the what we call as the warning shot in spikes protocol. So patients are attendants are already told that your child is, though the history is very brief and she is very young, but then putting the child on the ventilator itself is a very critical condition. So then the patient's family, when she will be on the ventilator, they are already mentally actually prepared that their child is not that well. And then on the morning, what I will suggest is, though this should not have happened, whatever has happened, but then it has happened. So we will have to call the parents, and then if possible, because only the SR and the JR was there, if possible, because she is such a young patient, so much emotions are involved in her. So if possible, we should call this a senior consultant, senior doctor in whom the patient's attendant have trust. Then once the doctor comes, consultant comes, if he can come, then he will be briefed about the updated about the medical condition of the patient before the talking to the attendants. And then most commonly what we do, I have seen is that the attendants are communicated right at the door of the ICU along with other attendants most of the time. So that is not a proper way of communication. We should, in this case, I would like to invite 2 attendants, not 1, 2 attendants, because this is a grave situation. 2 attendants in a private cubicle or a private space where we will get adequate enough privacy and time to talk to each other. Then, because the family members are already actually mentally prepared for something, then gradually first we will try to assess what the patient already, what the attendants already know, what is their perception of their illness. It may so happen that the attendants are already aware that their child is in a very critical condition, and if they are aware, they are educated, they are aware, then it makes our job more easier. And we should also see whether that they are willing to they are mentally in a good mental set makeup, that they should be given the bad news of this cardiac arrest. At many a times it may happen that mother and father have come and they are crying, they are not in a state to hear anything. So in that case, I think we cannot directly break the bad news in front of them. We may ask for some other attendant to accompany. Then gradually this breaking of bad news cannot be uniform to all patients, all attendants. We have to tailor according to the individual concern. So it should be done in a stepwise manner, in such a way that the impact of the bad news is lessened, but then it facilitates acceptance and this one understanding. So and at the same time, we should be very much clear of what we are intending to say. It should not be that much abrupt, it should not be too long, it should be brief, it should be sensible, and it should be clear what we say. And then we should also prepare ourselves for what the emotional reaction will be of the patient. So in that case, we have to acknowledge whatever emotional reactions the patient attendants develop after hearing the bad news. It may be most commonly after extubation, if this has happened, the most commonly the reaction will be of anger, or it may be a reaction of grief. So whatever, we must acknowledge their emotional reactions, and then we should be emphatic. And then we should allow them to ask questions whatever they feel. And at times they will ask some questions where we do not have any answers, like why this has happened to our daughter, why God has done this to us. Now, for those type of questions, we do not have any answers, and in that case, we should not be giving any answers, because at times silence is also good. So after these counseling and all, after communicating with the then we should ensure that whatever we were trying to make the attendants understand, whether they understood or not. So in that case, we will again repeat. We will ask them whether you have understood what we are saying, and then after that, we will, if they are in a good mental condition, we will then discuss the subsequent management protocol with them. That's what I have to say in this case.
Thank you very much. Actually, Spike's model is very important. There are a number of models will come later on, because setting is another thing very important. Once we set up the in a separate room, privacy and confidentiality is one. Another thing is it's just like once this Sonu Nigam was playing, singing at one of the station, and no one was listening him. There was Bombay's news. So people are not interested. They get a lot of information. They got registered. Once you go to the separate room, the registration is also important. What you want to convey. If you said something casually, it may not be get registered. Once the serious information is there, it should be very important to have a setup. That's a very important thing. So we had very rightly said, that's why there's some modification that gives some information and put a shot and see how the patient reacts. Then we can give in a piecemeal sort of information. If the patient is not able to comprehend that information and is reacting too much, we can hold the information sometime, or we can use some techniques like sandwich, sometime going back and forth, what we call the helical communications style. So that is also very important in such situations. Thank you very much. And the another thing is we have so many models, Dr. Anjum, and there are 10 or 15 and conversion of one model and other thing. If you go through that, the same. It's just like many gods, and ultimately, if you go to the literature, every god looks like the same sort of teaching and preachings. So, and what do you take on these models and how to apply these models in various situations? Does it make a difference to go one or other model, or what is the soul of these all models, if you can tell?
Thank you, sir. I agree with you. There are so many models now, and every so often you see a new publication which is supporting one particular model. I think if you go through the models, they're all the same. They cover all, like you said, they're the path to God. So there's so many. They're actually the same steps in a different acronym. I think we follow spikes in our institute, and I think all the other protocols, including pewter and breaks, are basically the same thing. But I would emphasize on attention to detail. Like Sir said, that in your setting up, did you give privacy to the patient? Did you allow them to sit down? Did you give them the respect of sitting with them, giving them enough space to speak? And like Dr. Pratibha said, what was your modulation? What was the kind of words you used? So in each of the SPIKES, there are finer points which we need to really pay attention to. So in the in the setting up, you need to see also whether, of course, how well you know the file, and whom are you communicating with? Is it the decision maker? Who is the significant other? Whom are you talking to in that conversation? Is he the legal decision maker? You're talking here. Your patient is not an adult, so we need to also be sure whom you're talking to. Another important aspect of breaking bad news, which we always take care of, is that we do it in person. We rarely do it to a single person. It's always in two or three people, in case that person himself has a bad reaction, has a vasovagal reaction, or has a problem. So pre-COVID, our basic rule was you never communicate bad news on the phone. It's always in person. And usually we try to look for at least two people who are decision makers or who can support each other through this difficult course. In perception, like you said, very, very important to understand what the family knows, because you build on that. Like Dr. Das said, you build on what they have already understood. Uh, um, we had this, I'm giving you a real case scenario. We had this 74-year-old gentleman who admitted his 71-year-old wife who had malignant bowel obstruction. And we wanted to tell him that she was very sick, and her BP was falling, her urine output was low. So we kept telling him, call your sons, call your daughter, we want to talk to them. So he said, my sons are busy at work and I can't disturb them. Then after a few hours, he came and said, I want to talk to you. So we asked him, uncle, what's bothering you? What exactly do you want to know? We were with the understanding that this gentleman did not have full understanding of the situation. His first question was, all the fixed deposits are in her name. Should I change the nomination? He had a full understanding of how sick she was. He was so pragmatic. And here I was tiptoeing around him to say, call your son, call your daughter. He had a full understanding. He understood that she was so sick that she might die anytime. He said, should I change the nomination? So very important for us to understand what the family has already understood and then build upon that. It helps us. You might waste time. Also, it's important to have your agenda covered. Empathy is important. Compassion is important. But what is your agenda? Do you want to take DOT consent? Are you taking consent for explained high risk? So what is your agenda? You also have to communicate and document. You spoke about the warning shot. I'm not sure how many people are aware of the warning shot. If you notice in any bad scenario in your personal life also, if you're telling a family member that X has died, you always begin saying that I have something which is bad to share. I have some bad news I want to talk to you. You don't suddenly say dash died. So even in a patient scenario, you begin with saying that the report is not good. I have some worrying news to share. That is called the warning shot. And you proceed after that with a technique which is ask, tell, ask. So you ask them what they know, you tell them something, and then ask them something else, and then you build upon that. Again, Dr. Das said, and I think Dr. Ganeshan also said, we need to confirm what they have understood. Because you might be very clear in what you have said. Unfortunately, many of us use jargon. We will say liver metastasis, or we will say the report is positive. When we say I work in a cancer hospital, and very often when patients are sent to us saying that you don't need further chemotherapy, some family members assume that they are cured and therefore do not need further chemotherapy. My oncologist is trying to say that the chemotherapy is not working, so they cannot have more chemotherapy. So the perception might be totally different. It's very important for us to understand
That's
what
very
the
common.
patient.
That's very common. That's very common.
Yes. So, what is the perception of the family? What have they understood from that reference? So it's extremely important to begin. Don't assume that they have understood or they have followed what the referring physician has told them. So at each step, actually, these are the finer points of every protocol. And since when you follow one particular protocol, you get comfortable with that. And I think we should follow one rather than saying, I know all 7 and I can follow these 7. In the apart from warning shot, we need to be careful that you're not using too much technical jargon. You're using the dialect that the patient follows, or you have a translator who can explain the exact words that you mean, so that there is no confusion in what you have said. We also want, before closing, to ask the family to reflect on what you have said to them. It's happened so often that you have told a family that the BP is low, the output is low, this is stage 4 disease, we are palliative care, we are not cancer specialists. And the family says that we followed everything, but is there anything that I should be worried about? After you've talked to them about lowering BP and lowering output, they will say, but kuch ghabrane ki baat to nahi hai. No, so they have not understood the actual context. So it's very important to understand what they have understood and document that and then build upon that. It might be that they really haven't understood, or maybe they are coping with denial. So we really need to understand what they have understood and then build on that. And of course, supporting emotion, strategizing and summarizing what the further next steps are so that the family is helped in the further management of that particular condition. I hope I've been.
Yes, thank you very much. I think documentation is a very important aspect. There are two types of documentation. One is getting cross-signed by the patient attendants also. Sometimes before starting, we tell that what we are going to tell you is we are going to sign both of us. So you have any query, you break us in between. You can ask, stop us and interrupt us and take the information. And sometimes most of patient attendants will sign. Sometimes there is a refusal also. But if the refusal is there, that we also document in the file that patients it has denial is there. So I think very important is the communication gap is there. We should try to fill it up if possible. Yes.
Sometimes also what happens is that we assume, we jump to conclusions. For example, in my unit, it has happened once that a family came and asked us that how much more time. And because we're a cancer hospital and we're dealing with so much stage 4 disease, we assumed he meant how much more time, how much more life. And he was asking how much more time for discharge. So we really need to know exactly what the question is. We need to know exactly kya janna cha rahe ho. What do you want to know? And why do you want to know? Rather than jumping to a conclusion.
Yes. Thank you very much, Dr. Anjum. Now, see, we also so many models and we have a different scenario also. But major blunder leading to cardiac arrest during procedure patient is a little different scenario. So we can have, I won't be going to the models. There are so many models, but everything is same. But in communication, there is a lot of, because Dr. Pratibha also told this thing, that everyone told, that is when we are breaking the news, more than the words, sometimes is your body language. So now I'll come to Dr. George Thira, that what are the barriers when we are breaking the news and non-verbal communication, because sometimes the linguistic barriers are also there. Sometimes you are just without telling anything, silence can be a tool of communication. It works both ways. If you're a good listener, silence is different. But if when you want to speak, important is there. If you don't speak, that's also a problem. That can be deadly also. That happens if you see in aviation. There are a couple of cases where the silence has led to the crashes. But here the silence is sometimes a very good tool, because in the silence you speak a lot. Just with the that movie by Kamal Hassan. So the total movie was silence, but it was total communication. So what do you take on this aspect? Non-verbal communication and the barriers we have.
Hello, sir. Am I audible, sir?
Yeah.
Yeah. Good evening, sir. My regards to Professor Bajwa, my friend, for organizing such a nice, program for us. Professor Gautam, who is the moderator of today's function, and then all the learned panelists who are here with us. A very good evening to you all and greetings from ISA Nagaland. Well, the question that you have asked is what are the barriers in breaking bad news? So I think whenever any patient comes to the ICU, they always come with a lot of expectations, and also there are a lot of emotional reactions from the patient party who have come along with the patient. So one of the main barrier is the expectation of the patient and also the emotional condition of the patient as well as the patient party who come along with the patient. And also another factor which we need to take into consideration is the cognitive deficit which they might be having because of the seriousness of the disease or maybe the ignorance of the patient and the patient party. And another important factor which we often encounter, especially with our junior colleagues, are the fear factor among the doctors themselves or the health workers, to break the bad news to the patient or to the patient party. Sometimes we feel that, if we break the bad news to the patient or the party, there will be some aggression or some negative reaction from the patient or the patient party. So even this is also one of the barriers that we often come across with new the junior doctors or the junior nurses who are in the ICU. And another thing which we should also take into consideration is our capability and our capacity as intensivists, those who are working in the ICU, how much knowledge we have about the disease that we are treating, or how well versed are we with the management protocols that we are following in the ICU. So our capabilities and capacities are also a very important factor in the breaking of bad news. And sometimes what happens is whenever we receive a patient, some out of compassion or out of enthusiasm will give a very optimistic picture about the condition of the patient. So in the initial phase when we do that, and afterwards suddenly something goes wrong and we have to share the bad news to the patient, it becomes a difficult situation for us to share the bad news since we have already portrayed to them that the condition of the patient is okay, he'll be fine, and all those compassionate words. That's why sometimes I feel whenever we receive patient in the ICU, we should be very careful from the initial phase what we are telling them. And as the previous speakers have spoken, I think it's very appropriate to explain the gravity of the disease with which they have come to the ICU that at the time of admission, which should be explained to the patient if possible, as well as to the patient party. And another thing which we should take into consideration is like the situation that Sir Gautam has explained. The patient was okay, was intubated, and there was an accidental extubation in the morning. So this is actually the failure on the part of the ICU management team. So it becomes an embarrassing situation for the in charge of the ICU or the doctor who is going to break the news to the patient. Then coming to the role of non-verbal communications, as the previous speakers have already shared with us, I think our facial expressions, how we talk with the patient, how we talk with the patient party, our eye contacts, how we, look at the patient. I think we should always squarely look at the patient, show our compassion, let them know that we are concerned about the condition of the patient and we are with them in this time of sorrow. So, as they say, eye is the window to the soul. I think the eye contact is very important when you are dealing with the patient or the patient party who has come to the ICU with a serious illness. And also the posture of the doctor or the nurses who will be talking with the patient or the patient party is very important. Even the space which the other speakers have already emphasized. Here I would like to add that in my ICU, what we have is just adjacent to the nurse's duty room, we have made a small space where whenever we have any case who needs to be explained, we will call either the parent or the uncle or somebody who is the decision taker in the patient party. And from that space, there is a glass barrier through which they can see the whole ICU. So we will take the patient party there, and then we will explain to them what is the condition of the patient. At the same time, they can see the patient through the glass barrier, which also adds to our communication skill, that we can explain that, see, this is what is going on inside, and so his condition is like this. The things that we are doing are like this, and we will do for the best, but anything can happen. So that is one space which we have created, where we take the patient party inside there and explain to them. So I think even the space where you explain to them is very important, and
Yeah,
how closely you sit with them and then you discuss about the case. And I think last time when we had a meeting, I had explained how we do in our place. I would just like to give a small example. For example, our hospital, we have a hospital chaplain. So the duty of this hospital chaplain is every morning to come and pray for any serious patient, whether in the ward or in the ICU. He cannot enter the ICU, but from the door of the ICU, he will pray for all the patients. So when we know that the condition of the patient is deteriorating and he may expire anytime, we always inform the chaplain that this is the condition. So you be around, and if necessary, we will call you to the ICU. So this is one practice which we are following in our hospital. And then another thing which I would like to share is, in mainland India, Hindi or English is a common language, so you can communicate with that. But in our state, since it is a tribal state with multiple language, what we always do is we always try to identify a health worker, a nurse, or an attendant who is in the ICU, who shares the same language with the patient or the patient party. So any bad news to be communicated, the doctor or the nurse will take that nurse or attendant who shares the same language or who comes from the same area, so that they can communicate with them in their local dialect. And I've seen that when we do that practice, it helps a lot in shooting down the patient party who sometimes are very aggressive. So I think most of all, the most important is how you react and how you talk, how confident you are. The previous panelists have said, if we show that we are scared, they will think that this doctor does not know anything. He must have done something wrong, or he must have given some wrong treatment.
yeah,
So I feel confidence is a very important thing when you deal with this type of situation, where you have to, break the bad news to the patient or the patient party. And one thing, there is a small mnemonics, they call it value. So I just want
yeah.
to read out this VALUE, where it means value means, V stands for value the statement of the family members. A is acknowledge the emotion of the family
I put on
members
the
who are
slide.
there. L is
Yeah,
like listen to the family members, because that's the time they might like to say so many things which you may not like to listen, but we have to patiently listen to them. And then U stands for understanding who the patient is in the family, and who is the person in the family who is taking the decision, or who is going to take the decision of any situation. Then the E stands for you elicit questions from the family members. So I think we should be ready to answer any question that the family member throws at you, and try to answer as far as possible in a very humble and confident way. So, sir, that's
thank you very much.
some.
I think very good thing is you have put a very close one, that is improve the counseling nearby. Compliance in the taking the privacy and confidentiality. If it's very nearby, it becomes very easy. Uh, so that's when.
So what we do is there's a glass barrier. So from there they can see the patient.
Yeah, we have put even camera in one our ICU where the liver transplant, the isolation is completely. We can't take the patient too close to the patient, but we have put some camera. It's far away, but we switch it on only during the counseling, and sometimes that also helps. But the interpreter and they are better connect. Even when we are giving the some bad news, sometimes we call a very senior person who is known to the patient's attendant, may not be part
That's
of the
right.
treatment. That also helps a lot. I think. Thank you very much. Your words are really very, I mean, good. So we have a lot of these things. But then the question is, we have taken the structure a little bit. Now there are a lot of scenario where the things are going to be tough, and everyone have gone through that. Sometimes the gray code activation, because how to apply these knowledge and narrative values every time we learn from these experiences. So different patient values, different family values and approaches different depending on the scenario. Also, sometimes I have seen one day one of my residents while putting a center line, the guide wire also was thrown into the patient's. It went to the heart and going into the pulmonary artery, then guide wire. So you have to go with another procedure. And the patient and was telling you are leaving these fellows unsupervised, and you are making our patient sick for that. And you want to go with another procedure for rescue. They are not able to listen. They are not comprehending. I mean, it's a really difficult situation sometimes at midnight. Then how to react those situations. It's really so. Now I'm starting with the difficult scenario. So because that was previous part was
Dr. Gautam, can I just add to the previous thing? They actually
yeah.
many times when you're giving bad news, patients are in denial. So there is a small technique which is called a broken record technique. So
Yeah.
you have to keep repeating the same thing in a very, very slow and with a low tone. It makes a lot of difference because they are in denial and they may not actually, like all the
They
other
don't want to
speakers said,
register. They
they
don't
may
want
not
to.
actually understand. Yes.
Yeah.
All right.
That's
So
very
I'll
important
take this
technique.
question. Yeah.
So
I just take this question. Yeah, this is the thing that we all fear the most. And this is like a serious adverse event in the operation theater. And let me tell you from my years of experience that there are three main important challenges for the anesthetist. One is to decide the cause of death. The second is, where to declare death. And the third, if there is no death, but just a serious event, and whether you need any transfer to a different, setup or a higher setup because of lack of infrastructure. So these decisions have to be made while you're giving CPR. Now, what I have seen is that many times the surgeons and the anesthetists are in conflict with the actual cause of death. So many I have seen in a few cases that the surgeon has actually gone out by the time even CPR is just going on. They go out and say that, yeah, I haven't even touched the patient. It can be really damaging for the anesthetist, especially if it has been just a spinal, shock or intubation problem. The other real problem is when the surgeon wants to shift the blame to the anesthesiologist, like saying that, the surgery has gone off well, but the patient is not coming out of anesthesia. So these are extremely damaging. And I always, kind of have if, in these rare cases, I always try to hold the surgeon back. And you should not, the anesthesiologist should never be alone when the bad news or the serious outcome is to be told to the relatives. And I am very, very clear that for any reason, if the surgeon is in conflict, please call your colleagues, call seniors, and only then take your time to kind of deliver this bad news. And conflicts can be really, really very damaging for the anesthesiologist. And even if shifting, whether to shift or not to shift, the surgeons, the hospitals, there are a lot of things which come onto the anesthetist shoulder. And please, we must not shy away from calling 2, 3 senior people to just assist us with and clear thinking. And they will be able to actually help us, because at least there should be 2 or 3 people when you are confronting the relatives. The other thing is that the hospital or your wherever you are working must have a protocol to decide. There are some people, mostly we do not like, kind of declaring death in the outside the operation theater. We always try to get back some rhythm and shift the patient to our own ICU. But shifting to another setup without ECG, or like without having a rhythm, is not beneficial at all. At that point, one has to kind of declare the outcome in the setup itself, because there are many instances of violence where the receiving hospital will say that the patient is
Not dead.
dead, and that creates the real problem and violence, and it really goes off very, very badly, because already the patient's relatives are in losing hope, and then you just send them because you don't want to declare death in the hospital. So that should definitely not be done. And I am of kind of firm opinion that you need 2-3 calm minds when this kind of scenario takes place. I have seen many, many fights with good friends who are surgeons, but they do not want to take any responsibility, and they would at any point like to shift the blame squarely on the anesthesiologist's shoulders. And basically, because all poor outcomes can be can be related to
I'm interrupting in
anesthesiologists.
between. Do you have some protocol? Because you have faced such things. Even I have faced a couple of these things. One of my medical student, we have a arrest during a very small operation where the father is a doctor also, and he was not aware of my son is going to surgery, only son, and a medical student. And we face such a difficult scenario. I mean, it's not easy. I can understand the amount of stress and all those things we go through. But the question is here, do you have some protocol in your hospital while declaring such patients on table deaths, like third party assessment,
We
whether
do
the
not. See,
tube was in the
if it is a
like
bigger
those things?
hospital, it makes sense. It makes sense to shift to the ICU. So the warning shot comes when you are, kind of when you know that the things are not going to improve. That from that time, and I am a firm believer that we should not, stop CPR till all these things are clarified. So I just continue CPR in good faith. You just continue CPR till all these things are sorted out. So you talk to the surgeon, you talk to your management, talk to the ICU people, just continue CPR. This is what I firmly believe. And I don't know, but so far, even after half an hour, you do get rhythm. That rhythm is your, you can work, or you get a little bit of time to kind of to shift to the ICU. But if it is out of the premises, out of the building, I suggest that the whole team has to come together. They have to decide on the cause of death. That is very, very important. That you have to say that what has gone wrong, but the surgeon standing by the anesthetist is the most valuable thing for the anesthesiologist. So we usually try to get back rhythm and shift to the ICU. At when the patient is being shifted, we tell the relatives that the patient is not doing too well, or if we had to kind of curtail the surgery, you must immediately tell them that the surgery has not gone off as planned because there is some problem. And it is always wiser to keep saying the blood pressure has fallen, instead of saying there was an intubation problem, or you keep saying that the saturation is falling, the the what do you call it, the blood pressure is falling, the patient's rhythm is low. So keep kind of talking of the condition. Do not talk of your differential diagnosis, at least at that emergency point. Later, you can reveal the thing. Just now, you just have to say that the heart rate has fallen very low. We have given CPR. We are doing the defibrillator. So everything positive that you are doing, we put the syringe pumps. There is inotropic support going. This also gives you time, and it gives you time. Senior people can come, and then finally slowly you can kind of reveal what exactly happened, but you do not have to give it. So the damaging thing is in case the surgeon has already gone and said कि tube ही नहीं गया or something like that, then it's really really very
No, it's
difficult
very difficult. I
for
know
the
that. It's so
anesthesiologist.
difficult. Thank you, doctor. Because we have seen it. Because what we do is
Right,
in
sir.
our practice,
Surgeons do not want to get involved with
no
any
one. Once
anesthesia
the things are
related.
bad, no one wants to take the ownership. That's always
So
there.
call colleagues. So I am very, very clear. You call colleagues because two or three senior people, kind of in the room and with the relative. It is not easy by any standards. It's just not easy, but quietly, when people see, there are only two things. And at this point, I feel there are only one thing that you have to avoid. You cannot think of the litigation, or just one thing you have to avoid is a anger reaction or violence. Okay, so just taking time and kind of talking in a slow voice, keeping on repeating things, addressing their emotions like people have said before, really gives you a little bit of time. And you keep saying that we will come back, please sit here, we will come back. And that also gives you a little bit of time to kind of rearrange your thoughts.
Yeah.
Anesthetists alone to give bad news is one of the
No,
worst
no, it's
things
a
that can
blunder if you
happen.
go alone. What we do is, I have faced a couple of times these things being a big setup. So, come across the complex surgery where the patients are already very sick. Sometimes we have to declare it on table, like if aorta has opened up on table or something has gone too. So it's very difficult to get the patient out also. What I do is, or my the colleagues are doing here is, sometimes we call the medical superintendent or involve them also, so that then the surgeons and other things will be aligned in the same way,
Yeah.
because it's a
Yeah.
hospital's
No,
reputation,
in
not that.
smaller setups,
Yeah.
there is a problem.
So
In the
then
bigger setups, yeah.
we have a lot of risk management also, like attending, because there is a lot of emotional trauma to the person who is conducting an SCR. So that is also not in a stable condition to do the things. And lot of back on
All
mind in
people.
that we may not get be beaten up outside, or then losing the job and all. There are so many things at stake. So one thing is dealing with the aftermath. I have practiced a number of places in the world. I have practiced in Sweden, Canada also, and then, because there are a lot of, in the university hospitals, these things do happen. I've seen the opening of a sternum, then losing the patient because everything is opened up, starting from the atria to ventricle, everything. So what do they do? They have the protocols which helps a lot. So records are also very
In the
important.
bigger hospitals, it becomes easier. In the
Yeah.
smaller setups, and especially unanticipated. See, when a person is going in for a neurosurgery, going in for a cardiac complex surgery, the patient's relatives are already, kind of,
Mentally
when you're taking
prepared.
consent, when you're taking, already primed a little. A tonsillectomy death is something that, it's whichever protocol you use,
It's difficult.
it is very, very.
Ah, that's another important thing
So
is,
complex surgeries, patients are already primed a little with your with
yeah.
your consent and stuff.
But important thing is altering the record. In the risk management, we should not alter the record. That is very important. If we want to put something, we put additionally and assign it. And otherwise, if you are altering your record and making things in the court of law and all these things, put a mistrust also. And in the court also, it's not considered good. It's still under false information. Another thing is personal record is very important at that time to make, because whenever we have gone with such complications, we may not put on the record, but we keep the personal record. After 10 years, if something goes to the court,
Yes.
you have a
Yes.
lot of alternatives when you are working on these patients, because patient may sue not immediately, but later on also. That's very important to keep in the personal record. And another thing is like risk management, take care of the patient, continue, don't leave the patient, and that's very important. If something has gone wrong, follow up in the ICU, follow up with the attendants, and go along with the intensive team or with the other doctors. And it's very important, if investigations are required, if something is erroneous or blunder has been gone because of you, and the hospital should waive off those things. I mean, communicating with the relatives and try to avoid disclosing news death over the telephone. That is very important. Telephone is always a serious matter. That's the only. So that is one part. Then another thing is media may come into picture. You have to be very cautious about these things. Don't leak out. Don't surgeon ask the surgeon to. I have seen a couple of times surgeon leaves the OR prior to you, and there may be extubation complication, and the surgeon by that time has told that I have done the surgery, the patient is absolutely fine. So that puts every blame on you. That's also very important. So department has to come forward for risk information. The leakage of the information is, don't discuss in the department also. Sometimes we discuss in the department these mortality meetings, but the risk in, there is a leak of information, the chances are always there. We should try to have a very close meeting in the confidential people, but not open in the public, because these are the things, if leaks out. Yes, you want to say something?
Debriefing, yeah, some debriefing in a later stage with, non-judgmental,
Debriefing,
what we
I
could do
have,
right.
yes, debriefing it to a sword actually. People have found debriefing may create a problem also, and may help also, because when the debriefing is done in a stress environment, it's not that helpful. Dr. Shamik wants to say something. Dr. Shamik, you want to say something?
Sir, sir, it is an excellent, like Pratibha ma'am has just nailed everything she has said. Two things, sir, I just want to add is that whenever there's a death in the operation theater, the police comes in. The OT is shut down till because it's a unnatural death. So in a small setup, till the entire thing is over, the OT will be shut. It may take weeks to months. So it depends upon that whether we are ready to do it or not. So it is prudent to shift a patient to a HDU or a PACU or maybe an ICU, and that will save a lot of hassle. Number one. Number two, sir, it is prudent to for every person inside the OT who has been involved with patient care during that time to write it in a separate sheet of paper, not in continuation. So that
Yes.
can be attached, and not in continuation for obvious reasons. The most important, which ma'am said, and I reiterate, which is not a problem in the armed forces, is a teamwork, and everybody is in one team, because today I am saving the surgeon's back and tomorrow surgeons will save my back. So it is a team, and the team stays for a longer duration, maybe years of 15, 20, 30 years. So this is a problem we don't face. But I think whatever ma'am said, and the medical legal aspects are very, very important to protect our youngsters who are listening to this forum, and they might have this problem. They will have a problem in life,
Yeah.
sometime in their life, where an elective case goes wrong.
Yes,
Emergency
thank you.
case acceptable.
Yeah.
Sir.
Thank you. Right. I mean, there are a lot of things to one we learn through these things. So another thing is the difficult case scenario is when the patient ended too aggressive, and what are don't and do's in the breaking the news. I'll come to Dr. Anjum Khan, because uh, sometimes patients are really difficult. What are the very important points? So I think can you just comment 1 or 2 minutes, because we are running short.
I think Dr. Pratibha has covered all the points. The only thing I wanted to add is that, like, your team should be available. If it's a surgeon, is a medical oncologist in the ICU, your team should be there. Do not face family alone. If you think it's an aggressive family, journalist, neta, politician, influential person, see that you have security backup. Make sure that all of you are on the same page. Sometimes the ward boy has other stories which he can leak. So make sure that your whole team, each member of the person in the operation theater or in the ICU are on the same page, and you have their confidence. Hospitals I have seen have unfortunately been penalized, because one hospital in our city waived the fees of a patient after there was a complication, and
Yeah.
they treated the patient for 1 month. And the family later on said that the fact that the hospital waived the fees, that means they were culpable. There was some mistake or some error or some blunder made by the team. That's why the hospital waived the fees. So be very careful when saying waiving fees. Be very involve your hospital lawyer, involve your hospital medical superintendent or the higher ups. And as ma'am said, your whole team should meet the family together.
Yeah,
And
that is very important.
and
That
like
is
sir
very
said,
important.
records, and if now in EMR, you cannot in any your EMR records get sealed immediately. So you be very careful what is documented in your EMR, because your EMR, there is no question of later on adding something that you forgot to say. EMR is sealed immediately. There is no golden period. There is no safety period.
That's very true. So secondly, the anger part is very, very short period. That's very important. If you are a good listener at that time, and what we do is when we are going with these, when we smell something that patients attendant are going to be naughty, or there is something, because I still have one experience when one of MLA made me a call when I was looking after COVID ICU. It was huge. Patient was shifted from there. Someone told that the patient is going to be fine. Absolutely. So, but when the patient is having on ventilator, how can you say in COVID, the deaths was so coming common? And he called me that come out outside the gate. So I immediately smelled that something is going to go bad. So I immediately informed the security people that be on back, but don't come till I say. So that's how we do sometimes, because sometimes security part also, if they come in along with you, it leads to little provocation also. At the same time, you have to be alert that should not be alone. There should be a backup plan always. And thirdly, what you said, the waving off in complication, that's really two-edged sword. So now I'll come to the later on this also, that how we go with the mixing of the words is very important. I mean, we should not be uh, never give false reassurance while using the thing can be done. That those are things we should try to avoid. We have now another thing what we is I'm coming, that is very important part. If some mistake has happened, should we confess or should leak it out? How do you handle? I mean, this is a difficult question. This has been a lot of surveys from US also, FES CRAM. If something goes wrong, and sometimes the team member tells other team members, leaks out the information, or sometimes it's a legal obligation also, and the moral obligation also ethical, that we should be honest. So how do you take Dr. Anupam Das on this aspect? I think it's the most difficult question to practice rather than telling it.
Sir, I think I may differ from the other panelists. I would like to confess, actually. I would like to confess. But then I will have to see the scenario. Say if I am working in a rural hospital where there are no security, I cannot confess there. So I have to consider the scene where I am in, because as many people have discussed about violence to doctors. But then I would like to confess if it is convenient for me to confess in the scenario, and then because it has legal and ethical reasons, actually, because and it's demonstrate transparency and integrity. So it may so happen that it may reduce the risk of litigation if at all it happens. But if I clam it up, then I may get a sense of security initially, but then never know if it gets revealed later on, then I will be in a soup. That's what
Thank
I
you very
feel.
much. I
I will
think
confess,
that's the best
but with
quality.
proper documentation,
Yes.
and taking steps that it will not happen again. That's what I
Yes,
feel.
it's just similarly when you are caught red-handed with your someone else in a lighter vein, then how to react? That is the way. If you made some blunder, then just telling the truth or hiding it, it's a difficult scenario. I think Dr. Shamik or can comment more. How much disclosure, if we are making the blunder, how much is safe disclosure, and can we disclose harmful, or how much, what should be the content, what should be approach? Well, that's the art. So how much disclosure should be there? Well, this is in the USA practice also now.
Yes, sir. Yes, sir. So disclosure, as Dr. Anupam was also saying, and I think honesty, empathy, and education all makes
Can you
a.
come near the mic?
So I'm audible, sir.
Yeah.
So honesty, empathy, apology, that by the acronym HEAL, HEAL, is a good way to understand the components of disclosure. And of course, awareness and lessen chances of future errors. Now that comes into audit. As we just told that audit is something or a debriefing is something which should be done in an unjeopardized environment. It cannot be done in a jeopardized environment where you try to do something good about the system and then you only get stabbed in the back. So unjeopardized environment, if it is there, it is at most important to do an audit because we have to find out what the error was and what the violation was. If it is a routine thing that is happening that has caused a death or a mishap, that has to be understood. So definitely, if it is a patient who is there and we need to understand the dynamics and acute death, yes. So disclosure of all harmful errors, as the slide says, it is very important. Is it important to tell everything to the patient's relatives? Is it important to tell everything to the patient's relatives? Is something that we do not disclose everything. We disclose that amount that probably they can understand, comprehend. They're not medicos. And last 26 years of medical knowledge, 26 years cannot be told in 5 minutes. And for them, for us, it may be for them the patient is everything. So everything need not be told to the patient. And yes, sir, if we are unprepared or we do an improper disclosure, that might be harmful. So we need to do our homework. We need to revise what has happened. Now, problem happens is that one physician has attended to the patient, somebody else has given anesthesia, and you are encountering the complications. It can be other way around also. Tomorrow you can be the victim. So good teamwork is there. The team has to be one. All the anesthesiologists, the staff, the paramedics. At times, the paramedics let you down a lot. You might have done an excellent job, but couldn't save the patient. Before you go to disclosure, the patient's relatives are already knowing about what has happened wrong. So prematurely delivery is totally no-no. We have to have a strategic approach. We should know how to go about it. And has an error or a violation taken place, so address it. And of course, a poor presentation, a less of showmanship, less of preparation can rise to a lot of loopholes, which might be a question to from the relative side. So I guess that is what it is, sir. And we do have a little amount of difference in the armed forces that we don't require security because we have got a hospital which is a defense hospital. And so I'll encourage all the youngsters to join the army, whoever it is. So that thing is sorted out.
So I'm just skipping a couple of questions in view of timing because to have more of important information, although we have a lot of Dr. Ganesan, I'm just skipping this question because sometimes the family is not just going to answer rather than all questions. When the family is not accepting the diagnosis and influential, how you go with the things in communication. So very brief so that we can
Yeah, yes, definitely. Actually, they will be in the denial mode because the patient looks fine, but you are telling something opposite. They will initially will be reluctant to accept that, but you need to persuasive to understand the situation, and you'll have to explain to them in a gradual manner that they understand the gravity of the situation. So it is really going to be tough
so
when you make the
you go
patient
with
close.
one meeting, multiple meetings, or if the patient is not accepting, you go with the treatment, or you want to give the autonomy to them or to ourselves. Although we have discussed already this thing.
Yes,
So
sir. And also they may throw suspicion on you whether you are telling the correct thing, whether we have chosen the right place, the right doctor. That might also come up in the mind, but that definitely you'll have to take someone from their family into confidence and who understands. Then you'll have to explain the situation. Probably that evidences might explain them about that. That's my
thank you very
point.
much. So very difficult sometimes happens is patient is recording your. You come to know that he is recording you. So how you react, Dr. Thira, or anyone else want to answer this? Dr. George?
Yeah, sir. This recording, there was an incident during the COVID time. It happened with me while shifting the patient on a, cylinder to my ICU because the whole hospital was in a chaos. The patient was gasping, and he was on a mask. One of the brother took the video of it, and it went viral. So it was spreaded in all the media, and we had a tough time. So after that, what we did was, I think I don't know if I'm wrong. You may correct me, but the government does not have any specific rule on whether a person can record a video of a patient or any sick patient in a hospital. I think there is no particular rule, but each hospital has the right to formulate their own rules. So after that, we have formulated a rule that until and unless they get the permission of the medical superintendent, nobody is allowed to do any documentary or even take a picture or video with their mobile in the hospital, which we have formulated, and we have given a copy to the commissioner of police of our this one town. So in that way, somehow we are controlling this, though it may not be very effective. But as of now, after that incident, we have not had any incident till now.
No, this is as per public places. You can record any public this thing. The hospital is also a public place. Patient attendant cannot record it. But sometimes over when we are taking the counseling and things, we also know that patient is recording, and sometimes telephonic discussions they start recording. The only thing is our what we do, although it's not allowed without permission. There has to be mutual consent when you are recording. When we take the consent in the recording, we always tell the attendants that we are going to record it. That's
Mm-hmm.
our policy. Like we go with the
The
procedures and that. But at the same time, if they want or not want, we can take the consent also for that. But public places, no one is actually, as per the law, cannot record the public places recordings. But sometimes, if it's recorded, it's an evidence. So you cannot deny
the
it also.
the legal stand on
Right, right.
recording is that you are actually not allowed to use that video clip unless the consent is there. But you know how India is, everything is going viral. And by the time you take action on the person who has made it viral, it is almost impossible. But the rule is, in fact, even in tele medicine, the main thing is that once the patient knows and you know that it is getting recorded. That is why even in all the Zoom meetings, you will get I mean, that is the legal thing to do, that everybody must know that we are getting recorded.
Yes.
So that is,
So what I presume is always if patient is coming to my ICU, our every conversation and everything is getting recorded. So that is the
Mm-hmm.
best policy. But I think because sometimes if they are recording, we should not be violent also, aggressive also. That leads to mistrust. And smilingly, you can say that you can record. If you say you can record, they will switch off immediately. So, and because that
Right,
shows
sir.
that
Right, sir.
you are so confident that you are not going to and make your statements very calculatively. But that's very important at that time. So, last is in these cases, once the patient, like this patient has a death, then how to go end of life care or cadaver.
Right, sir.
I think it's a difficult, but it's a third party always. I'm taking this question answer of myself only because the short of time. Because when we are declaring such patient, once the brain death criteria is there, because always we have the grief counselors and other people, because same party should not be get involved in the this thing, and ultimately it's honesty. If you tell that this is the moral values and those stress upon those things during counseling, many patients, I still remember one of patient we had operated for pituitary adenoma transapenoidal approach. Patient, young patient, 25, 26-year-old male. And during surgery, we had a puncture the carotids to the transintestinal carotid, and we lost that patient. And we shifted that patient to ICU. We thought that a young patient, we are losing that also because it's our error. So we were not asking that patient to, and ultimately 1 or 2 days when we tried to declare the patient, and we didn't go for even organization consent. His brother and father came. Can we do some donation or something? What is the reason? Can I know? We know that these things do go wrong, whether it's your fault or God's fault or whosoever is there, or this patient maybe had done something bad in the past. So this time he can do something. He can donate the organs to someone else and do something good for the future. So every person is different. Rather, we were so much mobilized emotionally that how the people think sometimes. It's not always that patients or attendants are different. So just for the last one line message, if you have to give, what you want to tell every one of you. First, Dr. Pratibha, what do you want to say? One line message to the everyone.
Okay, so my one line message is that we can fast track treatment, but we can never fast track communication around that treatment.
Thank you very much. And Dr. Ganesan.
So you should show honesty and integrity. Definitely, the patient should be taken into confidence before declaring anything. So that
And
is most
George?
important tool of communication.
Yes. George? And Dr. Shamik, in the meantime?
I feel that I would say that if you're not faced
Yeah,
complications,
sir. I feel thorough case knowledge, a thorough knowledge of the case and confidence is the key.
Yes, Dr. Shamik, now you can go ahead, please.
Yes, I like to say that if you're not faced complications in the work, then we have not been working enough. So we should be actually ready to handle it. And the youngsters out there should not be afraid of complications and put them in a shell. They have got excellent faculty and seniors to support them. So just go ahead and do your bit, and everything will be fine when you do it in good faith.
Yes, Dr. Anupam.
I feel build trust at the very onset. Build trust with the patient and with the attendant. How to do it? By good communication. That's what I have to say.
Yes, Dr. Anjum, the last message.
One word: listen.
Thank you very much. I think all these components are important, whether it's a good listening, silence, or if you are a good listener, many of the problems are solved, like just at home. When my wife is angry, I always try to listen, never react. So that's the best way. Most of the times, after 2, 3 minutes, why you are not reacting?
Again, she will get angry.
That's the best way. Now hand over to Bajba. Dr. Bajba, it's your ball game all. You have taken a little more time. Unmute yourself.
It was an interesting discussion. The last part was always good. Reaction. I think when you react to something, your reaction may be perceived by others in a very, very different manner. It's a perception of the other person, whether you are a HOD of your institution or just a first year PG. So perception, your action and the perception is altogether a different scenario, which can always create a rift between the good understanding between the physician and the patient attendants. And regarding one thing which was discussed in the Dr. Anjum madam, she was talking about the waiving of the fees. What we have encountered in our practice that majority of times it is because of the fees the patient's relatives are protesting, not just because we waiving for ourselves. Rightly said that we should not bring up this matter to waive the fees of, but majority of times whenever we see the bills are so much high in the critical care, the patient may not be paying it regularly. And when the patient is on the ventilator, it becomes very unethical for us to stop the treatment, or when you're in, especially in the private institution. So it's very difficult to stop the treatment. You have to continue the treatment. You have to continue all the costly antibiotics and other supportive medications. And with all the expenses of the ICUs going up, and suddenly with 3, 4 days, if you continue this treatment, the bills goes into lakhs. And then the patient relative, when they know there's no hope of surviving, I think many times the drama ensues like that. To create that, you have created this scene, you have just killed a patient. So that is one way. And sometimes they threaten you for all those things that we will record this thing, or we will put the body in front of the road, or we will put the body in front of the police station, something like that. So many gimmicks are there which you will see, which you must have seen in your, everyone here must have seen in their life. So that is a very complicated scenario. But when it comes to discount or a waiving of the fees, I think one thing we always give them, the body is that body is there. Just see, tell them whatever you want to do it. But please preserve the dignity of a dead body. Dead body is for everyone. Please preserve the dignity. Give the respect to the dead body. You want to do anything, we can't stop them. But at least try to identify somebody sensible from the crowd. There is always one or two persons who are sensible because the crowd is very agitated and the crowd is very angry. The only thing is, at least one thing was also discussed about that rapport with your own hospital staff. It's not on that particular case. It should be a practice that we should be having a good rapport with our, right from the ward boy to the technician to the staff. Every day we should be having such maybe some drills also that to make such good confidence, intimacy with us that anything bad happens, how should we react? How should we act, and how should we be, doing our conduct during that particular time. It is not just one day game. It has to be, when you are working in ICU or working in such a critical area, you have to bring that rapport with the staff on a day-to-day basis, so that when these breaking the bad news really things happen, everybody should be on the same note, on the same platform. And that time, I think you give a role to somebody to identify a person. You may be directly interacting with the most agitated people, but there should be some team member in your this team who will be trying to identify and bring that person to at least a sensible person who can at least calm down those people at that particular time. That's very, very important, because it's very not it's very difficult for a doctor who is in charge, who is going to communicate everything. He may not be having eye contact with everyone. Those, at least your team members, they may identify, or somebody known to them. I think that's the best way to do the things at those times. Otherwise, there is no one is universal, whatever you call, solution to these type of problems. It has to be done on an individual and day-to-day basis also. That's, I think, was going to comment, but the panel discussion was going very good, but didn't want to interrupt at that time. So I
Thank you
think,
very much.
Gautam sir, we should be able to take some questions are also there in the chat box.
Yes,
I
of
request
course.
Swati and Niharika to take over the mic
Many
from here.
senior persons are in the house. I think they can give their comments also. They can ask questions also. We are quite, I mean,
Swati, just see which questions are there.
Yes, sir. Thank you so much, sir. I thank all our esteemed uh, members. Your contribution have enriched this discussion and provided valuable insights, sir. Before ending the session, there are few questions from the audience. Our first question is from Dr. Sadhna. Her question is, sir, how to break bad news when you already have agitated relatives?
I
yes,
think
anyone wants to answer it, this question? Dr.
I
Bajaj,
will
to
like
answer?
to I will like to answer this question
Yes, you
actually,
can go ahead, Dr.
because
Bajaj.
I faced this situation many times, because worked in three private medical colleges and I faced this situation so many times. Once upon a time, there was a crowd of almost 500. I was alone, and the young patient, died of that this one brain hemorrhage. It's a traumatic brain hemorrhage, accidental case, and the bone was just taken over this one. Craniotomy was done, decompressive, and the bone was kept in that abdomen. So the major concern was again the waiving of the fees. The bill amount came to a much, much higher amount, and all of them got together at just beneath the hospital and told that the kidney has been stolen from the patient body. And I think that's what doctors are doing. So at that time, at that time, I know I was young at that time. I was assistant professor. I'm talking
You're
about
still young.
no, but I'm talking about 2 decades back. So I didn't know the reasons or the the fallouts of the how to face that crowd. I just went. I think that was maybe a learning experience of all the people from the village. I think because my background from the village, that prompted me, or that encouraged me to go to face those people. At that time, I just told them, "See, I am standing here. You people all are standing here. let's go to let's take this body to a civil hospital. We will do a post-mortem. If the kidney is not there, then I'm there to be, you can give punishment to me there. Or if the kidney is not found, what punishment you should be getting? So that was the thing I think as conveyed in whatever you called in some Josh or something, more of immature type of behavior in that particular young age, but somehow it worked, and two or three people came forward, and somehow that thing was settled. From that time onward, the thing became more clear that the more agitated people are, you try to speak the truth, try to speak the truth, and try to be on the patient side somehow. Try to be on the patient side, be empathetic, not sympathetic, be empathetic. That is the best way to deal with agitated patients. And otherwise, there are so many reasons for agitation. If you count on your agitation, first is the monetary part. The second part is those relatives must have been, irritated with the behavior of the staff for a last 4 or 5 days. I think somebody from the staff also must have been irritating them. So that must have is also counting. Third, I think the communication between the doctors and the relatives sometimes may not be complete, or may not be, that level that the doctor is not talking to us regularly, not giving us the, the direct information. That is another thing of irritation for the relative. Fourth, the relative maybe, you think you must have discussed that Googling the thing, then getting a knowledge, half knowledge from the internet, and then they try to correlate that knowledge with the patient's condition. That's another thing they want to say, that whatever you were treating and what the treatment is, a standard treatment, that the gross difference. So that is another thing. So the agitation has to be very, very, to brought down to a level where you can really deal with them, and it's not a single man job. You have to have a team. With agitated team, at least for the time being, your ICU is very costly. At least the security person should be there, because that manhandling can be there anytime. In our present scenario, that can be anytime. At least some security people, some good rough guys should be there to handle that situation. In the same time, don't forget that we are also clinicians, we are also human beings, and at least we should be very straightforward, truthful. And I think the day-to-day contact and day-to-day rapport will be helping us. And suddenly, if you think that in the 5 days we are not interacting with them, and the last day we are interacting with them, that will not be a solution. It's everyday interaction is very important
That's
every day.
very true. Very true. I think there are a lot of studies on this thing. I know violence triggers in the violence. There are a couple of those also. Violence, one is the communication comes at the first on the top, that if the poor communication is there, if the patient loses, the family loses trust on the physician or the surgeon, that's where the first thing which leads to the trigger. Second is what you are committing, and if you overshoots, like if you are asking some this much amount is going to be there. If you are less promised and more delivery, that save you. But if you have more promised, less delivered, that always create a negative impact. That's another way of another thing that triggering. So if we can go to the second question, is it ethical to shift already dead patient to ICU? I think it's a very important question. I am taking this question myself only. See, there are morally, ethically, and legal. There are three things different. Legal is in the court of law what is there, but in the ethical is autonomy, beneficence, maleficence, no maleficence, and the justice. But this is the moral question. And it's not morally true. What our mind feels, the conscious, is wrong. It's wrong morally. So that's why Dr. Patwa said very rightly, if we have to declare the patient in the OR, sometimes we do it. But at the same time, the documentation of everything is very important. If patient got revived, we ship the patient to ICU, that's okay. But if something is there, it's difficult because closing the OT, then getting the total format it's difficult sometimes. We do something which is not good, but sometimes people do it. We are not disagreeing that people don't do it. Many places they try to avoid the declaration in the OR. But sometimes if it is there, we do it. That's there. Another question is, anyone wants to add to this thing? Or should we move to the next question?
Sir, one thing to be added here is, see, our society, our general mind makeup of the patient's relative when the patient is in the OT, unless until it's not an emergency. I think death in emergency is okay. We take all type of consents, a video consent, or take up of a high risk consent or a death on table consent. We take everything. but it's about the elective cases. Elective cases, then nobody is going to admit that our patient went healthy inside and you are
Yeah.
handing us a dead body. So that mentality is very, very difficult to wipe from our minds of our Indian population, because the honesty part sometimes can be very bitter, and it can
Yes.
lead up to the very, very different and you know very critical scenarios where the violence can also erupt, other things can also erupt, the medical legal issues will also come up. I think here we should have being anesthesiologists on both sides, on the OT side and ICU side. If the vicinity, if you are got ICU in the same vicinity, the same corridor, I think whenever you are reviving, when you know you are, may not be able to revive the patient, at least it's better to shift the patient at that particular time during
That's so
reviving
good.
to the
That's a
ICU,
right way, right time.
so that at least your mental barrier on your explanation, your communication will be of confidence rather than of remorse, rather than of something, because your reactions will be the first one to be reflected on the patient's relative.
Yes.
It's
Secondly, you get
not,
time also. You get
it's
time to
not, it's,
also.
uh, it's not morally incorrect. It's not morally incorrect, sir, if you are trying to revive that patient and the patient died because of some therapeutic misadventure, or
Yeah.
maybe because of something, maybe anyone's fault, maybe it's an anesthesiologist's fault, the technician or the surgeon's fault. It can happen to anybody at any stage in life, because we are dealing with the live human lives. It is pertinent that these type of incidents can happen, mentioned in the books, mentioned in the literature. I think the time to be decided upon depends upon your structure, your clinics, whether it's a small clinic or a corporate hospital or an institution. It also depends upon the work area, how the workforce will be able to help you out, how your credentials, at what level you are working, in what level capacity you can make the people understand, and your rapport with the patient, how have you dealt with them during the pre-anesthetic checkup, or how you have really make a rapport with the surgeon's team also. All these factors come into play before you decide to shift this patient to the
Very true.
delicate.
It's very
Depends upon
difficult to be
three.
Raja Harishchandra. It's very difficult to be Raja Harishchandra. Even Vishwamitra told that saying that no one is possible to live without telling a lie. But although Raja Harishchandra proved it, it's not easy. He has to face so much
We are
pain.
living in Kali Yuga, sir. We are living in
Yeah.
Kali Yuga now.
But even that time also. So another question is uh, how long relatives can complain in case of bad incidents? That's a legal question. Anyone wants to take the
Madam
yes,
Kane, Dr.
Patrava
Pratika
wants.
Kane. Madam, unmute
Unmute.
yourself, ma'am. Ma'am, unmute yourself. Your voice is not audible.
All right. Okay. No, see, if it is a civil case, 2 years is your limitation period
Very
from the
rightly said.
time that it has happened. But if the patient wants to bring a criminal case against you, there is really no bar. So he can say, I have found out something, even after 2 years, he has investigated or found out something. A criminal case can be lodged.
That's how the court
Limitation
goes. We
period
have
in
to
the
maintain the
CPA.
record. Yes, rightly 2 years. That is a record keeping also. But in criminal cases, even sometimes if some swab has been left or something like
New
that,
evidence. They say a
yes,
new evidence has come out, and it
there
is
is no time.
everybody's right to present that new evidence.
Yeah. So then another thing is immediately type by the patient attendant. Uh,
So just one more thing about disclosure, I would just like to just, kind of, it's a caution. When you are working in a big setup and you have a lot of people to support you, then probably disclosure is slightly, you can make more disclosure. In smaller places, it is always best. That is what the lawyers tell you, is don't accept anything, straight away in front of patient. You can document your problems and everything, but don't say, I did something. So it is actually a way of communicating. You say this happened, that happened, what else has taken place, but you cannot admit that you have made a mistake. It's called a deny and defend. So you get time to defend. Do not accept total responsibility. This is just one of the ways.
yes. So more of these comments only.
Yes, sir, we do have one more question from the audience. Should we get death on?
But this is already answered by someone in the Jyoti Matthews answered. This is high risk consent. So what we do is see in high risk patients, high risk consent is very important. That is a specific informed and those complications. Although there are thousands of complications on any procedures, we cannot write. So what we although in the court also they say the printed consents are not enough. It should be something handwritten also. That is very important. What we do is in our consent, we have the template where we add few things by our hand that makes more authenticity. These are the common complication. These are the alternatives offered. And at the last big complication like going with the ventilator and going to the multiple organ failure and shock. These things we do write including death then. So that is part of, but these consents are just like a policy, you go insurance policy, there is so much big papers. People say there it's accepted, but here when comes the judge always says what is written in your progress sheet in your handwriting. So those are problems. How the judge see how we do it. So anyone can add more to this. But
The other thing is consent, I mean, writing about comorbidities. Those are like your defense areas. Many times, comorbidities are not mentioned in the consent form. So I always advise that the comorbidities should be very clearly mentioned. Patient has diabetes, IHD, all these things. And then what are the possible complications? Then it becomes easier for the judge also to understand that the patient has got already three comorbidities, which are by themselves, can very, very rarely do we find. So we have a full column which says comorbidities, okay, and primary disease.
yes,
So
legal
that
is
makes it
another
a little
chapter.
easier.
Legal is another full chapter, as a, I would say, webinar, if we have to take it.
Definitely, these comorbidities also may confound the risk percentage in particular scenario, like that patient is IASA 1 category patient might have a risk for this complication that might increase with the comorbid factors confounding to the risk. That also may be
Comorbidities gives you a little bit of defense.
certificate. That
The
need
thing
to
is,
be.
there are specific patient where you can put the death risk, not for all. Like I'm a liver transplant guy. Sometimes we do with a donor. We put this. The literature says 1%, but putting in percentage for all patients, every patient is with a different comorbidity. It's not a good thing.
No, see, it's easier for them to understand that two,
Yeah.
three comorbidities are, are there.
Then another model is one we use is good and God is with us or God is not with the best and the worst outcome model. That's also another way of counseling. That if the God is with us, most of patient and they believe in God because that's our culture. Then we say if the God is with us, even if we something do wrong, it will be done automatically corrected in his own way. So this is the going to the outcome. And if this is the not with us, destiny is something differently written. This is going to the worst outcome, and we stand in between this place.
Sir, what now actually what I have adopted in the last 5 years when communicating with these almost the terminal ill patient or very high risk patients, two, three things I have adopted. First of all, always have a puja place at the out of the ICU or the patient theater. Let the whichever faith the patient is of, let them pray that, and always convey to them the doctor is not God. Make it clear. Ani aap Bhagwan ho. Arey, we are not God. We are a clinician with special skills which we can help to make the patient better. God is one for all of us. He has given
Yes.
us skills to raise the patient. That's all. We are just like you human beings. We are not God. We should not be elated by whatever they are conveying to you. That
Yeah,
is one.
that's very true. We are duty-bound persons.
Next is the video consent nowadays is very, very important. We already talked about it. Conveying to them that we will be recording this consent. This is important for pre-operative, and we are going to give you every information. You can ask all the doubts now only before we take up the patient, whether for the elective surgery or for the emergency surgery, especially for the emergency surgery where the risk of death is high or risk of morbidity and mortality is high. That is next step. That has to be done in a very swift manner. And moreover, these type of things keep on happening. You can't stop them. So always, I think we should be at that par with the patient relative. When we record, document, as Madam told, the numbering should of the comorbidities by 1, 2, 3, 4, 5, 6. These are the comorbidities. And any court of law, any judge, when you see so many comorbidities, no judge has any, authority or courage to deny all those facts when it goes to medical legal aspect. But
Absolutely.
first of all, we have to discuss all the things with the patient relative. Anything untoward happen, we have to come out first ourselves. That's what we, and right, we are not God. We are just human beings with a special skills. That is what we should be conveying to everything. And more importantly, sir, more importantly, the patient may come to you a second time operation, the first time whosoever had done, uh, may have done some blunders, may have done some negligence, but I think as a medical fraternity, we should not blame the other physician or a surgeon. We should try to rectify the problem, whatever we are getting in our hands, without blaming them, because we don't know, we never knew what was happening there. And more importantly, when we are dealing with such situations, it's always pertinent that we always explain to the patient relative as a team. The surgeon in the operation theater, surgeon and we anesthesiology should be standing together on the same platform. And in the ICU also, relevant physician who's under whose the cases that have been admitted, that physician or his representative should be there with you when you express as a team, as a doctor's team. I think that is more effective way of communication and acceptance of the facts. This is actually what we
Seniors, sir,
do. Especially
seniors
seniors.
must interact.
Yeah.
Yes.
Sometimes, death is declared by the junior most person who doesn't really know the whole story. That
Definitely.
is one trigger factor for violence.
So
The last question in the chat box is, sir, many places are not fully equipped. Should there be an audit of the hospital?
If you keep doing audit of the hospitals, 99% of the hospital in India will have the deficiency and negligence. Then you
and
can't
secondly,
do
this
it.
is beyond our.
It's
I'm
not
back
a
interrupting.
policy decision making, it's the policies, it's the individual hospitals. I think not the chapter of discussion in this our panel discussion here. It's very difficult to answer that question.
And secondly, it is beyond our capacity also because it's more of communication skills. If we are discussing legal, yes, we can answer those questions. Yes, as such, we should be equipped that ASA guidelines are there. So ISA guidelines are there. 82 within 2 years of ISA, we have this ISA have ASA's guidelines within 1 or 2 years. So I think it was 1982 when we had the guidelines that oximetry, capnography, essential
They're
monitoring,
coming
that
up.
percent. There are so many things. There has to be there. We cannot deny. That's guidelines are there. We have to adopt those guidelines. We have to follow those guidelines.
Yes, sir.
The anesthesiologist should feel safe, and one should, as far as possible, not, it's difficult to say, but anesthesiologist should feel safe.
Yes, ma'am. So that would be all in questions in the chat box. I will request audience, if there is any query left, they could take it now from the audience, or if they want to add to this enlightened discussion, they are most welcome.
There is one suggestion that's always declare limitation of your hospital and doctor in beginning and only and provide option and alternatives. I think this is a very valid point actually. Whenever you are dealing with the patient, always tell we will be able to do the best whatever we can. But since all things may not be under our cover, every patient cannot be referred to a tertiary care center. If you ask me, tertiary care center cannot, have the capacity to hold all the patient, and the patient themselves are not willing to go to the tertiary care center. वो होता है ना that particular idiom, धक्के खाने वाली बात कि वहां जाते हैं धक्के खाते हैं डेट नहीं मिलती. So that means they are more willing to pay in the private hospital. When the private hospitals, that capacity, you tell them that we will do our best. We have got this team, we have got these doctors, we have got this much of equipment. So we will do these type of things, but we will do best. Rest is the your one. Luck also, and the rest also, if any limitation comes, so we will tell. That's all.
Yes, sir. Thank you. That would be all. I think there are no more questions in the chat box also. Now I will request Dr. Bajwa.
Dr.
sir.
Niharika, Dr. Niharika, there is one question. Dr. Thakur Bhai has raised his hands.
I've already told him to unmute himself. Dr. Thakur, unmute.
Sir, good evening, sir. Good evening, madams.
Good evening.
Thank you very much for arranging session. We actually, I'm sorry, I joined very late. It is very good session. I would like to add one thing here that in smaller and peripheral hospitals, we used to declare our limitations, and in beginning only during pre-operative checkup for anesthesia particularly, uh, all the comorbidities along with that age factor must also be included. Younger patients, older patients, they do add like a comorbidity. So, and patients are relatives are also to be convinced for that.
Yeah, that's what I told. I just answered that part also. It depends upon your hospital and your capacity, your this one, the skills of your doctor, the degree, the qualification of your doctor. You have to declare. I think almost every hospital they writes a very high profile when they're private hospital that international exposure, the gold medalist, so many things are written in front of a doctor. I think that sometimes, goes negative when a complication happens. Otherwise, it's a good for a clientele making. But when it really bad thing happens, those things go for a negative toss up. So it's a double-edged sword. When you write certain things, it acts in both ways. You can pick the patient, you can also have to face the consequences. Somebody's asking.
Dr. Bajwa, good evening.
Dr. Naresh, good evening. Just let me answer. Somebody said asking about the YouTube. Yeah, it will be available on ISA NHQ at YouTube after this session is over. It will be automatically there.
Okay. Now I'll request Dr. Bajwa sirs to please felicitate honorable speakers for the day. Thank you, sir.
Yeah, sure. My screen is visible?
Yes, visible.
Yes.
Thank you.
Yes, sir.
Yes.
So, first of all, the master of ceremony, Dr. Parshottam Lal Gautam sir, a very senior person, a very helping hand to me every time. Whenever I ask for help, he always there to help me out. And without telling his credential, they are very small already. CV has been read, which has been shortened like anything. So, sir, thank you very much.
Thank you very much. Thank you very much, Dr. Bajwa. It was honored to have this pleasure to have this opportunity.
Thank you,
Sir,
sir.
good evening. Dr. Gautam, sir, good evening.
Good evening, Ji. Good evening.
Then Pratibha madam, she has all the the knowledge of the world about the medical legal cases in India and the medical legal scenario for anesthesiologist, and the presence really added to the this knowledge and learning today. Thank you, Pratibha madam.
Thank you. Thank you.
And Anjum Khan ma'am, always she is the caretaker of a bigger hospital in Jaipur of the palliative care and the end of life care. Is one of the great personalities who's been dealing with this type of very critical issues, and all our inputs have been very helpful in this making a learning a very good for everyone here. Thank you, ma'am.
Thank you, sir.
Ilango Ganesan, he is the person who is a partner to me. We both had undergone surgeries, and we know how the surgery really impacts us. And so he was the right person, being a medical student. I know how the things going on. Thank you, Dr. Ilango, for being here.
Thank you very much, sir. Thank you for the opportunity. Thank you, Gautam sir. Also, nice moderation. Thank you, panelists.
George Hirabai is from my own alma mater, the Northeast. I just gave him a call, and he was ready to show that all the Northeast things here in this meeting, because the Northeast is altogether a different land where the law of land obeys different things. Almost it's a hybrid between India and China. So that's why I think that was very important. The different types of tribes and that there are different medical legal implications. So that was a good show.
Thank you, sir. Thank you for giving me the opportunity to be a part of this.
Yeah. Thank you, sir.
Thank you so much. And through this platform, I would like to invite all of you to come to Nagaland anytime. Give me a call. My number is with
we will have a academic event there very soon. Very soon.
Very soon.
Yeah. And Dr. Anupam Das is from my same place from where I did my MBBS. So, Dr. Anupam Das, thank you very much. And you are managing a very big hospital. And we were a Cancer Institute. It was there also when we were doing MBBS. So, it's a very big. And thank you for joining with us today. Dr. Shamik, so always always a very energetic person. Shamik in the Armed Forces Medical College, Pune. Always is a secretary of SDISA. So managing all the affairs of SDISA and she academically oriented, socially oriented, and is a gem of a person. Thank you, Dr. Shamik, for being here.
Thank you so much, sir. And Dr. George, Dimapur is an excellent place. I've been there. It's a pearl of Northeast, and we'll get to meet you in Dimapur shortly.
Yes, you are welcome
Thank you, sir.
anytime. Whenever you once you drop,
Thank you, sir.
just give me a call.
And thank you, Pratibha ma'am, for your all the pearls of wisdom, and Purushottam sir for your moderation. It was awesome. Thank you so much, sir. Thanks.
And
Thank you.
Swati is from Pali. It's a new branch which was found only lately, Rajasthan. And just see the talent is from every small branch of India. We have got a talented, and she's a very talented, this anchor. So thank you, Swati, for being coordinating this event today.
Thank you so
Thank
much,
you
sir,
to
for
all of
giving
you.
the opportunity. I'm really honored, sir. Thank you so much.
Niharika Das is again, she is from the same land from where I did my MBBS from Guwahati, and she's doing SRship in AIMS. And she's a confident girl, and I think she will be doing more of such events. Thank you, Niharika, for being here as a screen coordinator today. And more thanks to Dr. Madhuri and Dr. Nishan, because in the background, these people keep on helping, keep on the technical preparations. All the events have to be technically prepared in a suitable manner. So Dr. Madhuri and Dr. Nishant are always there to take care of these things, to prepare the screen coordinators and the panelists so that everything goes in a smooth manner without any flaws. So thank you to both of you also.
Thank you, sir.
If any wants to give a suggestion, we can have one suggestion, then we can close up.
Yes, sir. Sir, sorry to interrupt. There is one more question in the chat box, sir. It is from Dr. Mohan Pathak. He want to ask, in general hospital, many times residents are facing violence because they are only present.
Yeah, that's the truth. That's the truth, I think, throughout the country. It's not in just one general hospital. It's in the civil hospitals also, even in the private hospital also. Sometime at the night, especially when the residents are alone, people are coming, they're doing the violence. I think it's the country's image has also gone bad in the international circle. We doctors alone cannot do unless until the policies formulation is from the higher authority.
Policy. So now everything is on policy, and everybody is actually, it has become a business, and economics and shortage of staff is now going to hit us really, really bad.
So it's a difficult scenario to hold on, but the only thing we can see, be on the protective side every time whenever we do these things. But still, it keeps on happening. It just happened in Punjab only 3 days back. Only one of the SMO, the senior medical officer, was assaulted also by the relative. So
Yeah,
it keep on
19th.
happening.
Yes, 19th of this thing.
Yeah, keep on happening. So it's very difficult to avoid such situations. But when these situations happen, they take a very limelight. At least the media brings them to limelight like anything. At least they are shown. Otherwise, so many criminal offenses are occurring throughout the country. Nothing is being shown. But this, if happens, it has come to the limelight immediately. And we, or IMA or ISA or everybody, the professional bodies are always right behind these incidences. So that shows, I think, in spite of these things, the unity is always there in the medical and surgical fraternity. It's always there. So if anything is there, so we can.
I think we can close down. Thank
Yes,
you.
sir. I think we can end the session, sir.
Yeah, it's a very nice session, and thank you
Yes, sir.
everyone, Purushottam sir, and all our
Thank you.
Dr.
It's
Pratibha
Puriya.
sir, Anjum Jodh madam, then Dr. George Thira, Ilango Ganesh, and Dr. Shami.
Thank you so much. Thank you so much, sir.
And thank you all panelists for a nice interaction.
Thank you, sir. Thank you, sir.
Nice.
It was nice to hear from you. We learned so many things from you this time.
Yeah. And everything will be available on YouTube. You can learn and relearn again, sir. I will also learn. I will revise the things again. A long
Okay,
question.
bye-bye. Good night.
Yeah.
Good night.
Good night, everyone, and long live ISA.
Thank you so much. Thank you so much.
Adana madam, good evening.
Yeah, good evening and good night as well. Thank you so much for a good session.
Thank you, ma'am. Thank you very much. Bye.